There we go. Thank you so much. So now I would like to introduce Dr. Nadia Ali. She is the founder of Functional Integrative Medicine Practice for Functional Holistic Healing. She's been practicing for 16 years. She's board certified in internal medicine specialty, board certified in integrative holistic medicine, board certified in the American Board of Integrative Medicine, a fellow of the College of Physicians, of the American College of Physicians, a member of the Institute of Functional Medicine, and she has certificates in the areas of nutrition, mind-body, Ayurveda, and Chinese medicine. And you can learn more about her certifications and her practice at www.theholistic.healing.org.
Thank you so much, Kathleen. So now I want you to know Frank. Frank Roski is a patient of mine, and I've had the honor and the privilege to be part of his healing journey. He is one of the most intelligent men that I know, and the way he started his journey was with certain questions. And I think it's important for us to know his story, because not only is it inspiring, but it basically tells us how a functional approach can actually reverse chronic diseases. So let me introduce Frank to you. Frank is BS in German and Business from Penn State. He is also a bachelor's in Science and Mechanical Engineering from Lafayette College. He's a third degree Reiki master practitioner. He's a licensed real estate agent, entrepreneur, real estate investor, and Forex trader. So with that, Frank, I want you to please tell us your story, and thank you for giving us the opportunity to share your story.
Well, thank you, Dr. Ali, for that kind introduction. Thank you. My story starts actually in 2019. Prior to 2019, I've never had any diagnosed physical problems that I can point my finger to or could remember. In January of 2019, however, I had during the holiday season, was right after the holidays, early January, a very severe anxiety attack, accompanied by dizziness and imbalance and a racing heartbeat, high blood pressure. It was a very frightening experience, and one that I've never experienced before. It was so frightening that that evening we called the ambulance, and I was driven over to the hospital because I felt like I was dying. That's how frightened I was. I wanted to just crawl out of my body. It was so bad. At the hospital, I was diagnosed that evening after a number of tests with hypertension, that I was also a pre-diabetic, that I possibly had cardiac issues because of my family's medical history. Both my parents had heart issues. My dad had 5 bypasses. My mother had valve replacement surgery. So it was, I guess, conceivable that I might have a genetic predisposition to these things. I was prescribed high blood pressure medication that evening, encouraged to see a cardiologist to see whether I actually had a family issue going on. I was kind of disappointed by what the doctors at the ER were telling me, that once I'm on blood pressure medicine, I would be on it the rest of my life. That was discouraging that evening, and I was sort of discouraged by the whole event. And over the next several weeks, I rejected that path of treatment, and I thought to myself, I'm going to try a different path. So I increased what I was doing already in my life. I'm a yoga practitioner, and I do meditate, but I rededicated my life to doing more of that and doing it with more focus and with awareness. So I did that over the next several months, and the symptoms did subside. So I was quite happy with that. I actually got off of my medications. I thought I had the problem licked, that I had solved this on my own. Unfortunately, in January, about a year later, this January of 2020, I had a second episode, and this one was even worse. Again, extreme anxiety, extreme fear, the same symptoms of elevated blood pressure and heart racing, sweatiness, shortness of breath, even sounded like COVID symptoms. It was quite frightening, to be sure. Again, I went to the ER because I didn't know where else to turn in the moment. And again, the same diagnosis was given to me, that I had hypertension and possibly heart disease, and that I should see a cardiologist. No mention was ever made of any root cause, and being an engineer, as you saw in my bio, and sort of a technical person, a left brain person, I wanted to know what's causing this. You know, do I have a real issue, or where does it stem from? So I started to do some research online to try to find a doctor that would help me discover the root cause. I found the Institute of Functional Medicine online. You can see the website there. And I scrolled through various postings by different doctors. I came across Dr. Nadia Ali's posting. And what intrigued me about hers, and after researching her website, I was further intrigued by her definition of functional medicine. And that's really what drew me to her and drew my attention to her practice. Functional medicine, according to her definition, is a personalized approach to the identification of the root causes of disease and the empowerment of individuals to heal themselves. That was really exciting to me because I felt like I had some control over my health and over my path towards curing myself. Too often we go to doctors and we feel like we're just in the system, but we don't have any real power over the situation ourselves. And this is very different with Dr. Ali. The doctor discovered my unique causes to the anxiety problems and the blood pressure I was having. It turned out that I really didn't have a blood pressure issue. My blood pressure came in spikes, and it was not all the time. So that was a key factor in Dr. Ali's diagnosis, that there was something else going on, that I really didn't have blood pressure issues per se. It was something else. And through a battery of tests, blood tests and urine tests, she found out that I had leaky gut and an irritated bowel. I've actually had what's called SIBO, which is small intestinal bacterial overgrowth. And I was dumbfounded, surprised by this diagnosis. I didn't think that's what would show up. However, looking back over my life, certainly at least several years before this diagnosis, I do have to admit that I did have problems with digestion of certain foods, especially dairy. I had problems with gas, intestinal gas, again with dairy and certain other foods. So it probably was going on for a number of years, and I just didn't recognize it. And that was the big surprise. Through further tests, Dr. Ali discovered that, again, the root cause of these issues, the gut and the SIBO, was even deeper. So we drilled further into the truth, and that was that my problem really was mold toxicity and other toxicities such as mercury, which probably came from my tooth fillings, as well as heavy metals and a number of petrochemicals that are floating around in my body. I really don't know where they came from, to be honest with you, but they are there, and these toxicities are actually causing the leaky gut and the irritated bowel. So that's how important it was to trace back the root cause of high blood pressure to something that wasn't even in a discussion format with other doctors at the hospitals or at the ER. Once the root cause was discovered, Dr. Ali empowered me to heal myself through various changes in my diet, in my lifestyle, and then healing the gut biome, and basically killing the bad bacteria that had developed over a number of years and replacing it with a good bioflora. Could we go to the next slide?
Sure.
Yeah. So since then, since the beginning of this process in 2020, in January, it's been 9 months now, I've had really a dramatic change in my life. I don't have these blood pressure spikes anymore. They're gone. I've been able to totally get off of my medication without any adverse side effects. My blood pressure range is well below normal. I'm very happy with it. My brain fog has decreased. I can think clearly. I don't have fear. My SIBO condition is gone. It's basically cured. And I have a dramatic increase in energy and stamina. I have a sustained weight loss going on and a healthy weight management. I'm not fluctuating in my weight as much as before. It's pretty stable. So overall, I've had dramatic results, and I'm so thankful for them. And again, for Dr. Ali for giving me the tools and the awareness to listen to my own body. I think that's really the key, is that through science, she helps us discover how to listen to our body and to find out what's really going on. And I do so wish that medicine overall would ask that real question in the beginning when meeting a patient, is what is the root cause? And I think that would set most of us and many of us on the right path much quicker and be life-changing. So again, thank you, Dr. Lee, for helping me to this point, and I look forward to continue working with you.
Thank you, Frank. It's really an honor. It's very gratifying when we see that people are actually able to have a complete reversal of their disease and how liberated they feel, because finally they get their life back and they know that they can look to the future with hope that they'll continue to be able to do well because they're listening to their bodies. And I completely agree with you that listening to the body is the key, and you don't need a physician to tell you what you need to do. You actually have a body that communicates with you. So I think that is really, you know, if I were to say that's $100 million statement, if you can learn it, then you don't need physician. You have your own physician within you. So that's great. Thank you, Frank.
Yeah, thank you so much. And Frank's story really shows that, like, even a mild case of IBS, that can lead to significant issues, and it can also lead to serious consequences. On the contrary, myself, I had pretty severe, like very serious IBS. I would double over after eating foods, and I wasn't sure which food was even the trigger. And I had severe nausea, and I was actually struggling with just to function and attend work, which brings us to Dr. Ali. Why are we discussing irritable bowel syndrome today?
So I think that 35 million Americans actually suffer from IBS. So it's a huge number of people who are suffering. Unfortunately, only 3.3% are diagnosed. And if you can look at Frank's story, I think Frank didn't know that he had IBS really, till all of that started happening. And most of us don't know that that's happening with us because we have had those symptoms for so long that we think it's normal. But what happens is that we keep on having diagnosis after diagnosis. So we would have high blood pressure, or we would have anxiety, and we keep on taking pills for those diseases, not realizing that there's a direct connection between what's going on in the gut and what's going on in the rest of the body. So that is about 40% of people who have mild IBS. And then we have the 35% who are moderate symptoms and 25% with severe symptoms. So these are the people who completely have no life because they're either running to the bathroom all the time, they feel bloated all the time, they have significant constipation, which is so bad that they have to use enemas. And so if you look at the consequences of something which is just IBS, a lot of times people say, oh, it's just IBS. It's not just IBS. If you look at Ayurvedic medicine, if you look at Chinese medicine, a Chinese practitioner or an Ayurvedic practitioner, the first question they will ask you, even if you go and tell them you have foot pain, they will ask you what's going on with your gut. And you may think that why am I being asked that question? But the truth is that over 90% of illnesses are directly connected to the gut. And so if you look at the annual visits, just for IBS is 2.5 to 3.5 million physician visits happen for IBS. And obviously these are not mild ones. These are moderate to severe symptom patients with a cost of $30 billion. So it's critically important that we address this issue and people realize this is something they can do something about, and it is directly related to what we are putting inside our body. And that is precisely why we are having this session, to raise awareness that IBS is not just digestive tract issue.
What is the conventional definition of IBS, and what are the limitations of the conventional definition of IBS?
So if you look at the conventional definition of IBS, IBS can be divided into 4 categories. So they say that if you have more than 25% constipation, and again, the question would be, what is constipation? Everybody defines constipation differently. Somebody will say, oh, I always go twice a week. I had a patient who said he only goes once a week, but that's his normal. Is that constipation or not? So most of the time, people don't even know how to define constipation. Then there is a diarrhea, IBS-D, which is if you have more than 25% of time diarrhea, then you'll be IBS-D. Then there is IBS mixed, which is if you have both constipation and diarrhea more than 25% of time, that's called IBS mixed pattern. And then the last one is IBS-U or IBS unspecified, where you have less than 25% constipation and less than 25% loose or watery bowel movements. So if you look at this definition, the primary issue with this definition is that it confines IBS to 2 symptoms, diarrhea and constipation. And you can have IBS without diarrhea and without constipation. And that is what I want you to understand, that this definition does not tell you that IBS is a major issue which affects and leads to multiple GI symptoms and many other non-GI symptoms. So that's issue number 1. Issue number 2, like I said, it's not only just that it affects all the systems of the body, but it is affected by all systems of the body as well. So you cannot treat IBS as just confined to the gut. What happens stays there. No, it is affected by everything else that's going on in the body. Number 3, this definition does not tell us what is the problem with the patient. So you could have 2 patients with IBS-C or IBS-D or IBS-M, and they would have completely different root causes. So you cannot put everybody in these 4 groups, because that is really not going to help the situation. And last but not least, it does not identify the severity of the disease, which is critically important. Like I said, for the mild ones, it's okay. But for the severe ones, I mean, those patients suffer a lot. And unfortunately, because it's not technically a life-threatening condition, nobody really pays attention to them. They think it's not a big deal, it's just IBS. But these are the people who have no social life, because clearly if you have to go to the bathroom, if you're constantly passing gas, it's very difficult to have a social life. You cannot have work if you're doubling over with pain, or your stomach comes out as if you look pregnant after every meal. It's very hard to have a life with that. Your relationships actually suffer. And some of these issues are so chronic, they're so long-term, that even the family starts to kind of stop having empathy with the patient, because it looks like this is never ending. And so it's really a huge problem, and none of that you can tell from the definition of IBS.
You mentioned constipation and diarrhea. What are the other symptoms experienced by patients with IBS?
So in addition to constipation and diarrhea, there is gas and bloating. There is belly pain, which could be severe. Stool urgency, if you have to rush to the bathroom. I had a patient, I just feel so sorry for this woman at the time when she was experiencing these symptoms. She used to actually carry a big bottle and gloves, because her job was travel job and there was urgency. So she couldn't just stop somewhere, and so she had to, if she cannot find a bathroom, she has to figure out a way to be able to poop. So you can imagine how this woman lived, at that point in time. There's mucus in stool, undigested food in stool, anal spasms. Randomly, you feel your anus is kind of starting to contract. Nausea, vomiting, gurgling sounds from the stomach. If you can hear that, that's a problem. Foul smelling stools. Reflux and heartburn can be a separate entity, but in a lot of cases, you'll find reflux and heartburn in patients who have IBS. So those are all the symptoms that you can get. And this, what I'm describing, is just gut symptoms. We haven't gotten to what is called the non-gut related symptoms related to IBS.
So we mentioned constipation, diarrhea, and incomplete evacuation. So what exactly is normal? What does it look like?
So this is the Bristol stool chart, and a lot of GI physicians actually use it. So what is normal? The type 3 and type 4 is normal. So what should a stool look like? A normal stool, first of all, everybody needs to have a bowel movement a day. If you are not having a bowel movement a day, whether a bowel movement or a couple of bowel movements a day, it means you are constipated. We are supposed to have a bowel movement every day. And at the end of it, you should feel that everything that was in there is out. So that is what we call complete evacuation. Thirdly, it should be long, firm like a snake, and it should not float. Fourthly, there should not be any undigested particles in it. So you have to look at the color of your poop. And I know some of you might be thinking, oh, this is gross. But no, this is the most important thing, because remember at the time when we did not have any diagnostics, the way we diagnosed diseases was through understanding what the bowels look like. And even now, it's very important to be able to look at your bowel and see if there's undigested food in there or not. You have to know, is it really foul smelling? If you are having constant gas throughout the day, that is not normal. If you have gas once a day when you have your bowel movement, that's completely acceptable. But it should not be happening throughout the day. You should not have bloating post meals. That is also abnormal. So those are the criteria which will help you understand this is what normal is, and this is what you have to look for.
You mentioned that IBS is a systematic disorder. What are the other organs or systems in our body that are affected by IBS?
So if you remember Frank's story, and I'm going to refer to that the first thing that you see here is that you can have high blood pressure. You can also have high fasting blood sugar and high triglyceride directly related to IBS. We actually have research which shows that. All of the stuff that you see here, we actually have data. There are papers which show that. People with IBS have also been found to have high risk of autoimmune diseases. They have high risk of asthma, rheumatoid arthritis, and psoriasis. They're also at high risk of what is called temporomandibular joint syndrome, which is pain in the jaws, which is also linked to anxiety. Irritable bowel syndrome patients have very high likely possibility of having anxiety, panic attacks, depression, bipolar disorder, as well as schizophrenia, because the gut and the brain has a very strong connection. The other thing you see is that a lot of times, people go to the bathroom, they have what we call urinary frequency, and they think they have a urinary tract infection. But that's not because of an infection, especially if it's happening again and again. If you have IBS, you might have what is called interstitial cystitis, which is bladder inflammation, which can look like an infection, but it's not an infection. Unfortunately, if nobody picks that up, almost 30% of patients with IBS will have increased urinary frequency from interstitial cystitis. If it is not picked up, then you will get antibiotics again and again and again, which will actually worsen the situation because you are killing whatever good bacteria is left. So it's important to understand and know that. IBS is also linked to sleep issues. I've had patients who say we wake up in the middle of the night, we have to go to the bathroom, we have to pass gas, we have to go to the bathroom. They can never go to sleep because at least once or twice we wake up. Brain fog, headaches, migraines, especially intractable migraines. I've had a couple of patients who actually had Botox because none of the medications was working. And even after Botox, they were having headaches. And there's direct connection between IBS and migraines. Fatigue, fibromyalgia, which is aches and pains all over your body. IBS has a direct connection to hormones as well. So we see women having vaginal spasms, they have pelvic pain, and they have what is called severe premenstrual syndrome. And like I said before, you have estrogen and progesterone receptors in the gut. That is the reason why women are twice as likely as men to get irritable bowel syndrome. And there is a very, very close hormonal connection to it.
What are the root causes of IBS?
So Sir William Osler said it is much more important to know what sort of patient has a disease than what sort of disease a patient has. So this is the limitation of a conventional approach. The conventional approach pays too much attention to the disease rather than to the patient. If you want to know the root cause, you have to stop focusing on the disease and you have to focus on the patient. It is not important to make a diagnosis because a diagnosis is merely a label. It is more important to know why that is happening. And that can only be figured out if you know your patient inside out. And so if you look at the gut-related causes, you can have two people with exactly similar symptoms, except they will have completely different root causes. So if you look at the gut-related root causes, one of the most important root causes, which Frank was also talking about, was microbiome dysbiosis. Microbiome refers to the gut microbiome or bacteria, viruses that live in the gut, and dysbiosis means imbalance. That's one of the primary causes of IBS. The second thing that you see is malabsorption. If your gut's ability to absorb nutrients or food is affected, you will have IBS from that. Food sensitivity. If there are certain foods that you are having against which your body is throwing an immune response, then you will have symptoms of IBS. Leaky gut. Leaky gut is a very important cause of IBS, and Frank referred to that as well. Leaky gut is simply that your intestinal lining is actually broken. There are actually holes in it. And because there are holes in it, that bacteria and toxins and viruses can actually enter the bloodstream. And then they can cause a lot of damage because now there is nothing to stop them from getting inside the body, while previously the intestinal wall was actually stopping them. Motility, movement. So there is something called MMC, it's migratory motor complex. It's actually a group of neurons which are extended all the way from the esophagus down to the anus. And these are the neurons which are responsible for allowing the movement of the digestive tract. So when you eat a food, slowly and gradually the movement keeps on happening. It makes the move forward and then ultimately lands the food in the anal area in the form of the stool. But if you have a problem with that complex, whether if your motility or movement is increased, then what you have is diarrhea. If your motility is decreased, then you either have constipation, or what happens, because the food stays in one place and then the bacteria eat that and they make a lot of gas, and then you have what is called bloating that you witness after meals. And if the movement goes in the opposite direction, then you have what is called nausea and vomiting. So that is another reason why we find IBS is directly connected to the motility. The systemic causes of IBS are, number one, stress. Whether you call it stress, anxiety, depression, all of those are directly linked to IBS because, like I said, the brain and the gut constantly communicate with each other. We also know that, that those who have had traumatic experiences either as a child or as an adult are more likely to have IBS. And that is a connection between the brain and the gut. If there are nutritional deficiencies, that can also lead to IBS, because remember that if you have nutritional deficiencies, your immune system is not going to work, which means your ability to get rid of bad bacteria is going to be compromised. And then, of course, if you have gut issue, then you have even lesser nutrients. So you can actually get into a vicious circle where you have nutrition deficiency causing IBS, IBS causing further lack of nutrients, and then you keep on going back and forth. Inflammation, a very important cause of IBS, and inflammation could be anywhere in the body. Inflammation could be because you have an underlying infection like mold, Lyme. We actually have data which shows mold toxins can cause leaky gut. If you are exposed to toxins, and I think, and the toxins can be medications too. Or if you have other toxins, like Frank was talking about, metallic toxins like mercury, or you have non-metallic toxins like petrochemicals, those can also cause leaky gut, and those can also cause IBS. Immune activation. So there are certain cells in our body called the mast cells. The mast cells release histamine. And so if you have immune activation, meaning your immune system is activated more than normal, then it's going to throw a tantrum anytime something will enter the gut. It will not be able to differentiate between who's the friend and who's the enemy. And that can also lead to IBS. And last but not least, as I had mentioned, hormones play a very important role in IBS. So all of those are factors which are outside the gut and can cause IBS.
You mentioned microbiome and how important a role it plays in IBS. Can you tell us more about the human microbiome?
So we are talking about more than 100 trillion species of these little creatures, and there are more than 3 million genes. So if you look at, if we have one gene, for every gene that we have 360 genes of the bacteria, which basically means that we are more bacteria than humans, because we carry more of their genes than we carry our genes. And there is a reason why we carry those genes. It is because of those genes that a lot of functions are carried out in our body. If we don't have those, then we cannot really function. So it is what we call a symbiotic relationship, which means that we are interdependent. We work for them, they work for us, and they work for each other too. So it's like a group of friends living together, and each brings something to the table. And because this relationship is symbiotic, any breach in that relationship is going to completely off-balance the entire system. So you can actually say that it's a new organ that we have found out that we carry in our body, which weighs almost 2 to 6 pounds. And they're everywhere in our body. It's very interesting that we now have found bacteria even in the stomach, where there is acidity, quite a lot of acidity in that stomach, and we have found bacteria there too. So they are in the nose and the skin and the sinuses and the vagina and the urinary tract, but most of them are located in the gut. So if you look at, when we talk about microbiome, most of the time we say bacteria, but it's not just bacteria. There are also viruses, there are also fungi, and there are also parasites, and they're all good. So not all fungi are bad, not all parasites are bad either. You know how people say, if there's a parasite, you have to kill it. No, you don't have to kill it. Because in certain conditions, like one of the very important conditions, inflammatory bowel disease is an autoimmune condition of the gut, where we actually insert bacteria in humans, and that actually helps achieve remission of disease. And there's actually papers about it. So not all parasites are bad. And so we need all of the good people, good bacteria, good fungi, good viruses, good parasites to come together, because they can all play a very important role in helping us lead a healthy life. So if you look at the role, the most important role of the microbiome is protection against pathogens. So remember that if somebody comes in our system and tries to disrupt this symbiotic relationship, these bacteria, fungi will become a barrier. They will not allow it to settle down. So they actually are our defense line, actually. The second thing is that they also make nutrients. So they make vitamin K2, they make B12. So if you don't have them, then you don't have the essential nutrients you need to function. The third very important role is immune system development. And this is where we say that, you know, if you have issues with allergies, if you have issues with autoimmunity, it has a direct connection with the gut, because it is the bacteria which can make sure that the immune system does not just become hyper and does not start attacking everybody. So this is what keeps our immune system calm. The next one is intestinal angiogenesis, which is the bacteria actually help us make blood vessels in the digestive tract for the supply of blood, for the supply of nutrients. And here you can see the next function is the function related to weight, because they directly impact the storage of fat. So there are people with IBS who will say they cannot lose weight. And there are people with IBS who will say that they cannot gain weight. And in both categories, the issue is the same. It's the type of bacteria that's present in your gut that is going to determine what's going to happen with your weight. And that's why when Frank said that he has been able to achieve or sustain his weight is because he has now a balanced microbiome which will not allow him to get excess weight, or it will not make him lose a lot of weight either. And that is what we call a state of homeostasis or balance. The next thing which is extremely important is what is called short-chain fatty acids. Short-chain fatty acids are actually, you can call them certain molecules like butyrate, which are made by the bacteria. We cannot make them, but we need them. So butyrate actually can reduce the inflammation of the colon. Butyrate can actually repair the leaky gut. Butyrate actually prevents colon cancer. We desperately need butyrate, but we cannot make it. We are dependent on the bacteria to make it for us. And then last but not least, their role is in the central nervous system, which means our brain and our neurons, because we now know that the gut bacteria can modulate, and their imbalance can cause neurological diseases like Parkinson's disease, MS, Alzheimer's disease. So that is another role that they play in this process. So if you have microbiome dysbiosis or imbalance, what can happen? One of the things that Frank referred to as SIBO, small intestinal bacterial overgrowth. So small intestine is an area where most of our digestion and absorption takes place. So if you have bacterial overgrowth in that area, obviously you will not be able to have the nutrients. You will not be able to digest and absorb your food. There is also another new thing that we are finding, which is called SIFO, which is small intestinal fungal overgrowth, which can also happen. The other thing is that you might have bad bacteria in your colon. You might have bad fungus or candida, and then you can also have bad parasites. All of those can cause what is called microbiome dysbiosis or imbalance, leading to IBS.
You mentioned leaky gut. Could you tell us a little bit more about leaky gut?
So I think this picture is a really good picture because it shows you that this is a normal gut. And what you see here, you see these are what we call tight junctions. This is what we call the security. Nobody is able to come through here inside the bloodstream. The only way to enter the bloodstream is through this area. This is called the brush border. The characteristic property of the brush border is that it will only allow completely digested food to enter, otherwise it will not allow it to enter. If you see here, this is what we call leaky gut, which is basically inflamed, and you can see there is no security at all. This is completely open to anything that wants to enter can actually enter. It could be undigested food, it could be bacteria, and the inflammation is so high that you can see the cell has actually broken down. And so it's basically an open area. There is really no security whatsoever. And if you see here, the result of all of the passage of these bacteria and toxins is that there's inflammation. So you create inflammation. Your immune system gets activated because the body is getting signal that there is an enemy that's entering the body, and that enemy is coming all the time because you have leaky gut all the time. So imagine if you press the 911 button all the time. Now the body is in a state of chaos all the time because it's constantly attacking. It's attacking everything that's coming its way because it's being asked to attack. There is increase in the hormone called cortisol, which is a hormone of inflammation. There is also an issue with the production of neurotransmitters. So remember, neurotransmitters are the chemical messengers in the brain and the nervous system. And when you have leaky gut, you are either not able to produce the right neurotransmitters like serotonin, dopamine, or you produce certain ones in an excess. The result is anxiety, depression, brain fog. There's, of course, impaired digestion and absorption. Obviously, I mean, if you are getting undigested food, I mean, clearly you will not get any nutrients from that. And that obviously leads to nutritional deficiencies. So it's pretty clear that leaky gut can cause a host of issues, which can then cause consequences associated with IBS.
You mentioned that leaky gut can cause malabsorption. Can someone have malabsorption without leaky gut?
Yes, definitely. So if you look at malabsorption, you know, your malabsorption issues can happen without leaky gut. And the first and foremost thing here is inadequate mastication. If you are not able to chew food, you know how we are used to standing up and eating? This concept of fast food, I mean, that's the craziest concept that we could have, that we accept it. That you are standing, sometimes you're sitting, some people are in the car driving and eating their food. Imagine you have no time to even chew your food, which is the most important step, because the saliva actually has enzymes which starts the process of digestion right in your mouth. So if you don't have this important step, you are going to have problems going down. Number two, very important, this is where I have been burnt myself as a physician, is, you know, most people are not paying any attention to the breath in their mouth. You know, if somebody says they have bad breath, or they say they keep on having, you know, bleeding in the gums, or they have pain in the gums, that is a sign of gingivitis. So basically what happens, all day long, you are swallowing your secretions. All day long, you are sending all of these bacteria inside your gut. And the reason why I said I was burned was, we had this gentleman who came. He was a young man. He came, he had SIBO, we treated him, we removed all the root causes. He goes home. We saw the test before, after, everything perfect. We said, yes, you're ready to roll out, we don't need to come. We see you in 6 months, something like that. And 2 months later, we get a phone call. And he said, oh, I feel like I have some symptoms. And I couldn't believe it. I said, how is it possible? You know, we have data to support, everything is perfect. I said, are you sure? Did you change the diet? He goes, no, I have not changed the diet. Did you change the supplements? He goes, I did not change the supplements. And I know he's telling the truth. Why would he not tell the truth? Then I get him in. I said, is there something that I need to know? Is there any other symptoms? And then suddenly he says, oh, sometimes my wife tells me that I have a bad breath. And I was like, oh no. And so I said to him, why did you not tell me this before? And he goes, it was really not bothering him. But that was the most important step, because that was the source of the bacteria. And so we killed everything, and now he keeps on putting it inside him. No wonder the symptoms were coming back. And then he said something even more interesting. So then I said, is there anything else? Because I just want to know once and for all if there is something that I need to do about it. And he says, I have postnasal drip. And I was like, oh, so if you're growing something in your nose and then you have postnasal drip, you put it all the way back inside your mouth. So now not only is the bacteria inside your stomach coming from your mouth, it's also coming from your nose and whatever you're growing in your sinuses. So it's very important that the mouth be taken care of. The next thing is your stomach. Stomach has acid. It also has something, an enzyme called pepsin, which is extremely important for protein digestion. So remember, we have people who take over-the-counter acid blockers. So sometimes they take omeprazole, sometimes they take Protonics, without realizing that HCl is critically important for digestion and absorption. Particularly certain nutrients like B12, magnesium, you need acid for that. Third thing, you know, if you have a gallstone, you are suggested just go ahead and remove it. And we remove it as if we don't need it. But remember that bile is extremely important for the digestion of fats. And yes, the liver does make bile. So your liver has to be functioning. The gallbladder stores the bile. So if there are gallstones, you have to ask the question, why are gallstones forming? Is there something wrong with the quality of the bile? Is there something else going on which is affecting my bile? And so that is very important for fat digestion. And last but not least, pancreatic enzymes are needed for digestion of fat, carbohydrates, and proteins. So if you have any issues with your pancreas, for example, if somebody says, I have diabetes, and I have I have inadequate insulin, then you have to think, if the pancreas is not releasing insulin, is it releasing the enzymes, or is that affected too? So you have to have a functioning pancreas in order to be able to complete your process of digestion and absorption. So all of those things can affect digestion and absorption.
You mentioned that hormones can lead to IBS. What hormones are involved with IBS?
So the most important hormone I mentioned was the cortisol, which is the hormone of inflammation. The second one, very important, is thyroid. Thyroid hormone affects literally every single part of the body. The third one is insulin, which is the hormone which regulates blood sugar. And blood sugar regulation is extremely important. If you have abnormal blood sugar regulation, you are going to have issues with IBS. Estrogen and progesterone, directly connected because we have receptors in the gut. Actually, the bacteria can affect estrogen, and estrogen can affect the bacteria. So it's a two-way relationship between the two. And so those are the hormones which are implicated.
So how is IBS diagnosed?
So if you, when we talk about diagnosis, then you have to look at what do you do from the gut standpoint and what do you do from the non-gut standpoint. So if you look at the gut, the first thing we do is we do the pH test because we want to see if you have adequate acid in your stomach. The second thing we do is the SIBO test. You know, it's a breath test that we do because we want to look at how much bacteria is sitting inside the small bowel. The third test we do is the stool test because this is the large intestine. And by doing the stool test, we can actually tell what type of bacteria are sitting there, whether you have inflammation there, do you have malabsorption there, all of that we can tell by those tests. In addition, we do a leaky gut test, which is a blood test. We also do a food sensitivity test. We have to assess your liver function. We have to make sure you have an intact gallbladder, or at least we can address that. And we want to make sure that you have a functioning pancreas. Non-gut related diagnosis would include assessment of inflammation, hormones, nutritional evaluation. We want to see if you have a history of mold or Lyme disease. We want to look at what kind of toxins you have been exposed to, including medications. We have to look at oxidative stress, which is basically production of free radicals. And we also want to see what's going on with the histamine and or mast cells. So those are all the things that we have to assess when we're doing an evaluation of IBS to know all the root causes associated with IBS. So here is a breath test. You can see this is a young girl whom I saw. A beautiful young girl. She was almost 22 years old. When she came to me, she weighed less than 100 pounds. And she had been to a lot of GI physicians. And the first question she had for me after she gave me her whole story, she actually was hardly eating anything because she was having diarrhea like 10 times a day. She said, Dr. Ali, am I going to live? Which was like shocking to me that she's only 25 years old. But I could understand why she was so frustrated. She didn't know what to do. She couldn't hold a job because of her diarrhea. And she was extremely fatigued. And if you see here, this is her SIBO test. This is the food entering the esophagus. So this is a breath test, and we are looking at two things, hydrogen. This is the blue line is hydrogen, and the black line is methane. So you're looking at hydrogen level and methane level, and you can see here you still have, this is the small intestine, and here it becomes large intestine. So right here you can see there is a spike in hydrogen, a direct indication that she has SIBO. We worked with her, such a nice person. I think she did really well. She was one of my very compliant patients. And right now she's married and she's a teacher, and we're very happy for her. And this is her test, you know, post. And you can clearly see that this is perfect, no issues. So I think that that's again a SIBO test. So after we treat, anytime we treat something, we have to do a repeat test because we want to make sure that even if symptoms are not there, actually are the bacteria there or not. So that's the SIBO test.
What is the conventional approach to IBS?
So the conventional approach for IBS basically looks at symptomatic treatment. So how do you treat symptomatically constipation? They start with fiber. Fiber can actually have adverse consequences in some situations, particularly if you have a lot of bad bacteria, because bacteria love fiber. Fiber is the food for bacteria. Laxatives. A lot of times when you have constipation, fiber does not work. Fiber especially backfires in people who have motility or movement issues. Because first you don't know how to move your bowels, and then you add fiber, which is like even more bulkier. So now you have put a lot of stuff in there that's not coming out. Laxatives, chronic use of laxatives can actually damage the colon. It can damage the muscles and nerves of the colon. It can cause electrolyte and mineral imbalances. It can cause dehydration. That's the other thing. The idea of a conventional approach is to try and use medications that would help relieve the symptoms. But the problem is that if you have to use this once in a while, that's okay. But if you're using it chronically, then you're not going to be able to ever get out of the situation. It's only going to be a temporary fix. And there'll be a time when whatever you're using, like if you're using laxatives, there'll be a time when laxatives will stop working. So then you'll say, okay, now next level of laxative. And now we're going to go to enema. And now we're going to go to this. But that will just continue. Last but not least, PPI or acid blockers I talked about. Unfortunately, these are available over the counter. And I think that's really a huge mistake. I'm not sure how this was allowed. But there are people who are on chronic acid blockers. And if I were to tell you the adverse consequences of these acid blockers, PPI, you would be shocked. It's interesting that if people were to know this, they would never, ever even go close to it. So the PPIs have directly been linked, and this is all the literature that we have. We have data about this. We have research papers on it. They cause nutritional deficiencies. They can actually cause kidney damage. They increase the risk of fractures. They actually increase the risk of stomach cancer. They increase the risk of pneumonia, small intestinal bacterial overgrowth, C. diff, Clostridium difficile. This is a bacteria which has serious consequences to the degree that you could actually have your colon removed if the infection is severe enough. PPIs actually increase the risk of heart attack, and they actually cause memory loss. I mean, the question is that, yes, this is a treatment. When it was initially studied, it was studied for 3 months, but now people are on it forever. So the question is that, is this really a solution, or is this the beginning of the problem? And so that is the problem, that when we use a symptom-based approach, and I would argue that even on a supplement basis, like, some people will say, okay, give me some supplement for the symptom management. You are still band-aiding the situation, and there'll be a time when the supplement will stop working. So you really need to find out, what is the actual problem and address that instead of trying to symptomatically address the issue.
So, is IBS reversible?
So I came across this cartoon, which I thought was very interesting. In the conventional medicine, you're supposed to live with your IBS till they find a cure. And you may have to die with your IBS if the conventional medicine is not able to find a cure. But in functional medicine, IBS is definitely reversible. There's no question about it. And how do you reverse it is really the question. It is not a quick fix. And I'm not going to make it sound like, oh, today you'll get some supplement, tomorrow you'll be perfect. No, it's an approach. It's a process where you have to know what's the root cause. You have to know what's the severity of the situation. And then you have to devise a protocol, because you want to identify and reverse all the causes that you have found. And we often use the 5R approach for that, and I will go over that. And then at the end of it, you're supposed to have a preventive plan, because it's not enough to kill. You also have to have a plan of how will you make sure that this thing does not come back. And that's what we call the maintenance plan. The 5R approach that I was telling you about is this. Number one, remove. You remove all that you don't need, whether it be bad bacteria or parasite. Number two is replace. Replace what you don't have. If you don't have certain nutrients, if you don't have enzymes, you replace it. Number three is repopulate. Find out what bacteria is missing. What is the missing piece that needs to go back into your gut. You have to repopulate, repair. It's not enough to kill. You want to make sure that you repair the gut that has been broken. And it's very important to repair it, because if you don't repair it, the gut function will still remain compromised. And last but not least is rebalance, which is what we call a state of homeostasis. How do you balance the gut back to the state that it was? So that is the 5R approach. In every individual, what you will be removing will be different. What you will be replacing will be different. What you will repopulate will be different. Your strategy of repair is going to be different. And your rebalancing plan will also be different. So even though there are some principles, but this is like, but you have to individualize the approach.
So how is IBS connected to nutrition?
So of course, the first and foremost thing is the deficiencies. If you have IBS, you have very high likely possibility of having vitamin deficiencies, mineral deficiencies. You may not have short chain fatty acids, which the bacteria make, such as butyrate, and you may have deficiency of antioxidants because of production of free radicals. But the other thing is hydration. Hydration is extremely important. We now know that drinking over 8 glasses of water actually helps both the IBS-C and the IBS-D, constipation and diarrhea. Diarrhea is the key, and Frank might be able to talk more about it because all my patients keep diaries, and that is the key. That is how you listen to your body. So when you hear him say that the key is listening to your body, one of the key ways of listening is to keep a diary. And maybe if somebody wants to know, maybe Frank can elaborate on it in terms of how he did that. It's not easy. I will tell you, it's not easy, but it's very, very, very informative. It's not informative for me. It's informative for the patient to be able to see what's going on and how what he or she is eating is affecting him or her. Food sensitivities, again, is something that is a relationship of nutrition to IBS, to know what foods your body does not like. And last but not least, prebiotics and probiotics. So prebiotics are what we call the food for the bacteria, and probiotics is the actual bacteria. And we oftentimes say, oh, prebiotics and probiotics are great. Not necessarily. In some people, prebiotics may exacerbate the symptoms, and probiotics may do nothing or may actually make things worse. So you have to know, who do you need to give prebiotics to? It's not for everybody. And what kind of probiotics you want to give, because it will depend on what type of bacteria you have. So again, prebiotics and probiotic foods can also be consumed, but you need to know, who do you want to give this food to? If you are feeding the bacteria and most of the bacteria are bad bacteria, then do you want to feed them is the question. And if you have a very high amount of bad bacteria and you put that patient on probiotics, there's going to be adverse consequences, because now there's a fight that you have initiated. You're putting something in there, and the ones that are there, they're not interested in giving up their spot. So that can actually be a problem.
So how is IBS connected to lifestyle?
Physical activity. We actually have research which shows that moderate intensity physical activity of between 30 and 60 minutes done over a period of 6 weeks can actually help IBS. And this is something you can do right away. You don't need to see a physician for that. Stress. If you have stress, you have anxiety, you have depression, if you control those things, you will automatically see your IBS symptoms will get better, because we know there's a direct connection. Sleep. We know that people who have sleep disturbances are 1.6 times more likely to have IBS. Why? Because we heal during sleep. Everybody needs to get 8 hours of uninterrupted sleep. That's the time we heal. Remember that the body, every single cell of the body has a clock. And then we have a master clock right behind here. And every hormone and every enzyme is released by the exact time. Similarly, there's a time for us to rest. And if you don't rest, then you actually create a chaos in your own body, because the system is not sure what it's supposed to do, whether it's supposed to rest, is supposed to release enzymes, not release enzymes, because now you're going against the system yourself. So that's very important. I would definitely say that if you're on alcohol or caffeine, then I would ask you to taper yourself off of those, because alcohol directly causes bacterial overgrowth. It can cause imbalanced bacteria. Direct connection between alcohol and leaky gut has been found. It can cause immune system activation, meaning it can create an immune system activation, which means that your immune system will become so active it will start responding to even your friends, meaning even the benign stuff that's coming through the gut will have adverse consequences, and you will have symptoms from that. Alcohol is directly toxic to the liver and directly toxic to the pancreas, two key organs that we need for digestion and absorption. Caffeine. There are two issues with caffeine. The first issue is that caffeine directly affects the motility of the gut, which we don't necessarily want to activate in people who have IBS-D or diarrhea. And secondly, caffeine is processed by the liver. So you don't necessarily put extra load on the liver that's already struggling in people who have IBS. So those are the things that you can try and taper off and help yourself.
So in conclusion, IBS is completely reversible using the functional approach. IBS is a complicated disease that affects not only the digestive system, but impacts many different organs and systems with severe and serious symptoms. The root cause of IBS can either be related to digestive systems and/or other organs and systems. The functional approach identifies and addresses all the root causes associated with IBS, along with a maintenance protocol to prevent further future reoccurrences. So next webinar will be a whole body approach to obesity, and that will be on October 24th at 4 p.m. So please put it in your calendars and please register as it's required, and the seats are limited. We will be covering what are the different body types, what's the connection between hormones and obesity, how does stress and trauma affect the body weight, what causes emotional eating and food cravings, how inflammation is connected to weight gain, what is the role of gut bacteria in weight management, fitness, sleep, sauna, fasting, and meal planning for weight management. So we'll be touching on all of those topics. And if you have any questions, or if you have any of your challenges that you're having pertaining to losing weight, please feel free to submit questions or anything you would like to Dr. Nadia Ali with the email that's provided, email@theholistic.healing.org. So I'm going to go ahead and look at some of the questions. So feel free to put them in the question and answer section. I do see a couple already. Okay. Why does SIBO treatment fail?
So we see people who have multiple rounds of antibiotics and they still fail the SIBO treatment. Either the symptoms never go away, or if they go away, they come back. And there are a couple of reasons for that. The first one, like I said, if you have not addressed the root cause, if you have not identified the reason why the issue is there, the reason can come back, the bacteria can come back because they have a reason to come back. That's number one. Number two, if you have an immune system which is weak, you are going to have reemergence. That's why immune system strengthening is one of the most important things in SIBO treatment. The third and very important thing to understand is that bacteria that are in your gut, it's not one bacteria. When you're treating urinary tract infections, single bacteria that you treat. If you treat pneumonia, you treat single bacteria. In case of SIBO, there are many different types of bacteria, and they're very smart. So they develop resistance very quickly. If you do one round of antibiotic, most likely they're resistant to it by now. So second round, third round, you can do as many rounds as you want. They have figured out how to take care of themselves. So it will not work. And that's why it's critically important that you don't use your weapons. You do not show your weapons to them till you have absolutely weakened them to the degree that you know that they will not be able to resist you. So when we have people with SIBO, they say, oh, Dr. Let's start the treatment right away. And we tell them, no, you're not going to start right away, because if you want to wage a war, then you have to have a strategy. You have to be very clear how you're going to attack, what weapons you're going to use, and you will attack at the right time. You will not just go ahead and start running towards your enemy, because this is not any enemy. This is a very smart enemy. And so you have to work with it in a very smart manner. And if you do that, then you will be able to overcome the issue.
What was the treatment for SIBO? Is one of the questions.
So there are many, many ways to treat SIBO. And the most important thing, like I said, is to know what has already been used. So you can treat SIBO through antibiotics, and you can treat SIBO through non-antibiotic or through botanicals. But like I said, the killing of the bacteria should not happen until and unless you have identified and removed all the root causes. You know, absolutely, you're sure that the power of the bacteria is extremely low and your immune system is extremely strong. Until and unless those things are taken into account, you cannot start your SIBO treatment. Next, if you're going to treat SIBO, you need to know what we call sensitivity of the bacteria. What bacteria is the primary bacteria that you're trying to kill? Because there might be one or two bacteria which will become prominent. Is there fungus along with the bacteria or not? Because then the protocol will change. So depending on what you're trying to kill and what it is sensitive to and what weapons have been used in the past, depending on that, you will come up with a strategy as to what you want to use now. So it's not a simple matter like, oh, you have urinary tract infection, just takes the Proflox for 5 days. And that's it. So that is not how it works. That is precisely why a lot of times rifaximin, which is the antibiotic often used to treat SIBO, actually fails.
So when treating SIBO or Candida, so is a healing crisis expected when we treat Candida or SIBO?
I have treated a lot of cases of SIBO, and that's actually a myth that there's going to be a healing crisis. In 97 to 90, so of 100 people, 97 to 98% people will not have a healing crisis at all. 1 to 2% will have a healing crisis which should not last for more than 24 to 48 hours. If it lasts for more than that, then you really have to stop because there's something else going on. So if you have treated the person well, if you have supported that person well, your chances of having a healing crisis is less than 2 to 3%. And even if it happens, it will not be more than 48 hours for the most part.
So what is the difference between IBD and IBS?
IBD, inflammatory bowel disease, is an autoimmune disease. That's a much worse case scenario than IBS. And yes, IBD is also reversible, but it's a very different approach. The approach that you take for IBD is very different than the approach you take for IBS. So if you have to pick, if you are given the choice of pick one, I would go with IBS anytime because that's not autoimmune.
And we have a question about Frank's story, it seems. So what about his symptoms pointed you to IBS? I assume you got him a GI map. He didn't have any gut symptoms?
So basically, Frank, you want to tell about what symptoms that you were having for the GI symptoms? They want to know what GI symptoms you were having at the time when we kind of diagnosed you with.
Well, excessive gas production for almost a lot of different foods, but like I said before, dairy was, I guess, the primary one. That was a problem. And I had problems, with the stool. I mean, irregular stool, not having bowel movements on a daily basis. Those were I think the primary, but I didn't have, the doubling over of pain. I didn't have that sort of issue.
So yeah, stool test, I mean, we don't do GI map. GI map, unfortunately, is a worthless test. Any test which uses DNA is worthless, because what happens is it will tell you everything that you have ever had in your lifetime. So there are people, I have had patients who came to my office, they ran to my office because they were so worried because the GI map picked up H. pylori. And now they're like, oh, we have H. pylori and this and that, and we need to get treated. And doctor, let's just go ahead and treat. And I said, no, this is GI map. How do I know this is active or not? I'm not going to just treat you because GI map said. And when we looked for active H. pylori infection, there are ways to look for active H. pylori. They did not have active H. pylori. And if you can have H. pylori, could be just a colonizer. It could just be in your gut without causing any problem. So you're not supposed to treat that. So that is why I don't use a test which actually just looks at DNA. You really have to look at a test which does culture. Any test which actually uses stool culture, and especially a 3-day test, is a better test. And in that test, the best thing is microscopy. A pathologist looking at your stool to look for parasites and fungus. That's the most important thing that you want to look for in a patient who has IBS issues. A very trained pathologist who can actually pick up stuff. And culture, of course.
So is there a test for the fungi?
Yes. So remember I said to you that the pathologist can actually find yeast in the stool. And then there's another test that we do. It's a urine test, which is the best test for fungus is the urine test, because it is very hard to grow yeast. You can see it sometimes, but you won't be able to grow it. And sometimes you won't even see it. Because remember that even though you're doing 3-day stool test, you could have that fungus in a part of stool that you have not taken for the test. But if you do the urine test and there is a marker, special marker called arabinitol or arabinose, in some tests they call it arabinose, if you have that marker, that's a direct indication of fungus that is in your gut and you see it in the urine. So that is a much better test if you are trying to look for fungus overgrowth.
How do you know which probiotics are working or what your body needs?
So that is why you do the stool test, right? Because the stool test tells you what you have and what you don't have. And depending on that, you make a decision of what kind of probiotic you want to throw in this person. You will not just pick up a random probiotic and start somebody on it, because the person, let's suppose you have a probiotic which is lacto-based, lactobacillus-based. Well, the person already has too many lacto. So why are you kind of wasting so much money and resources on that probiotic? Why do you not look at the stool and actually give that person what they actually need?
So how does a conventional doctor know which prebiotics and probiotics to prescribe?
Well, they don't really do the stool test. Usually what they would do is they would pick a good brand of probiotic and ask you to take it, hoping that it would help you. And a lot of GI physicians are now talking to patients and telling them to use good brands of probiotics. But that is not what we call customized probiotics. And that is the key. You need to try and customize it to the patient. And now we also know that probiotics like lactobacillus, let's suppose you say lactobacillus. Lactobacillus has many strains, and different strains are used for different diseases. So lactobacillus rhamnosus is very different from lactobacillus acidophilus. So not only do you need to know what bacteria you're looking at, you also need to know what strain of the bacteria you're using and why you're using that. And that is very important. Most people think, oh, I'm getting lacto and I'm getting bifido, but what strain of lacto are you getting? What strain of bifido you are getting is very important. It's not enough just to, because yogurts have lactobacillus. That lactobacillus is completely worthless because most of it is lactobacillus acidophilus. That's not what you need. Most of this data that we have is on other strains of lactobacillus. Plantarum, rhamnosus, salivarius. And so you really want to know what strain are you using.
So do you leave treating SIBO until after all of the other treatments are in place?
Definitely. The killing is the last thing that we do. Always. Killing is the last thing because, at the time when we use that killing, that patient has no symptoms by that time because we have weakened the bacteria to the degree, and the patient is like, sometimes patients say, oh, do I need to get treated? I don't have any symptoms. Yes, because we have broken the power of the bacteria, but it's still there. So you have to eliminate it, but you have to eliminate it at a point where now it has no power. And then you will move to starving the bacteria, which will be your first step. You starve the bacteria, and whatever resistance is left, that's going to go away. And then you go ahead and treat it, because now the success is guaranteed.
If I have episodes of UTIs that I'm being treated for, and one of my physicians said that it might be or is IC, is there a way to know which one I have?
Yes, you can. If you're having recurrent urinary tract infections, remember that what we do in conventional setting, as soon as you have symptoms, you're put on antibiotics. You don't want to do that. You want to tell your physician, it's the second time I'm having it, I want culture. So when you do a urine analysis, the IC, interstitial cystitis, and urinary tract infection look exactly the same. You will not be able to know the difference. But when you culture, if you have an infection, it will grow a bacteria. If you have IC, you will never grow a bacteria. And at that point in time, you should be starting to ask, oh, is it really an infection or is it just an inflammation? Should I really take an antibiotic for that? So the culture is what makes the difference. So there's no reason to rush on with an antibiotic, really. You really should wait and figure out the situation, and don't kill more of your good bacteria through antibiotics.
So how long does it usually take for SIBO, the SIBO treatments?
So the actual protocol of SIBO is usually between 2.5 months. But the problem is not that. The problem is the prep before that. So remember that in the prep before that, you have to remove all the root causes. That takes more time than the SIBO protocol, because SIBO protocol is 2.5 months. But the problem is that if you have 5 reasons, 5 root causes, then we have to work with 5 root causes to remove those, right? If you only have 2 root causes, then we only have to remove 2 root causes. So the timeline will really depend on how broken is the body. If the body is less broken and the body has more resilience, this is another term that you need to know, resilience. So I had a patient who was 60 years old. And when she asked me, how long will it take? I said, I don't know. But what I was thinking in my mind, I bet she's 60 years old. Will she turn around quickly or will it take time? I didn't want to tell her that it's going to take time, because remember that in medicine, you never say never and you never say always. You always should look at what's going on before you make an answer. You have to have some data to make that response. And interestingly, when we started treating her, within a month, that woman responded. And I was like, oh my God, she has amazing, amazing, amazing resilience. And she is 60. So I have 75-year-old patients who have responded so quickly. And I have young people that have not responded in like 4 months. It took me 4, 5, 6 months for them to respond. So actually what I found, and this was very interesting, because when COVID happened, they talked about immune aging. They talked about the age does not tell you if you're going to get into the hospital with COVID or not. It is immunity. What is the age of your immunity? That will tell you if you will be in the hospital or not. And the same thing is true for resilience. Resilience is not dependent on age. Resilience is dependent on what is the reservoir in your body to be able to heal itself. And so your resilience will determine how quickly your body turns around. And that is what really is going to determine how quickly we can turn around the root causes, and then how quickly we can start the protocol for SIBO.
Could a baby that has constipation and diarrhea, could they have IBS?
Yes. Actually, you will see mothers complaining about little babies, like infants. Oh, my infant is colicky. So think about it. It's a breastfeeding infant. How can they have colic? I mean, they're not even eating anything. What is that colic coming from? It's coming from the mother. The baby has eczema. How can a breastfeeding baby have eczema? It has something to do with what the mother is eating. If a baby is 1-year-old, 2-year-old, and they're having constipation issues, they're having diarrhea issues, it has to do with what's going on with the gut bacteria that they have, or what we are feeding them. Yes, they can also have IBS. We have a lot of patients who would say, oh, I was always constipated since I remember. Well, that's not normal. So yes, kids can have IBS.
How do you find a doctor that works with me to do these tests instead of dismissing what I have as IBS and just to live with it?
So basically, I think Frank mentioned a website called Institute of Functional Medicine. You can definitely go on that website and find a physician who have a functional approach and can help you with reversing your IBS. I think that would be a good idea. You know, we work virtually with patients as well, provided that you can come at least once to our office once a year for treatment. Or if you want to find something local, you can just put your zip code and Function IFM would tell you what are the list of doctors in your area and you can find somebody. Unfortunately, the conventional primary cares and gastroenterologists have no idea what you're talking about. And so it's not that they have any bad intentions or anything like that. It's just they're not trained in it. And functional physicians are trained in it. So you want to find somebody who's trained in the area that you want to seek help. And hopefully you'll be able to find somebody nice who can help you.
So this will be our last question. Do you do all the tests that you've mentioned on all of your patients, or does it depend on the symptoms?
No, we do not do all the tests on all the patients. I mean, that is what you call finding, that would actually make things worse because something will come back abnormal. A physician who does, you know, like this is one of the issues with conventional medicine. If you have a problem, they do a CAT scan of chest, abdomen, and belly and pelvis, and then something will turn up and then they'll start running after it. That's not the way you diagnose a case. You have to know what you are looking for. Then you do a test to confirm whether it's there or not the other way around. You don't try to find an abnormality and start running after it. So when we ask you to do certain tests, we have a reason, and that reason is from your history, from your exam, from your lab results. We can't just do all tests in everybody. How would that help the situation? It would actually make the situation even worse because we might be starting to look at something abnormal which may not even be a problem. So no, we are supposed to focus on tests from your history. And that's why I said that instead of focusing on the disease, you focus on the person. And what does focus on the person mean? Focus on the person means that you only do tests that are relevant to the history of that person. And then you go from there.
Thank you so much for everyone in attendance, and it has been a pleasure, and everybody staying to the finish. Thanks so much, and we look forward to seeing you on October 24th.
Thank you all. Thank you, Frank.